Allopathic medication, Part 20. Physicians may also reject evidence that conflicts with their anecdotal experience or because of the cognitive biases. For example, a vivid memory of a rare but shocking outcome, the availability of heuristics such as a patient dying after refusing treatment. They may overtreat to do something or to address a patient's emotional needs. They may worry about malpractice charges based on a discrepancy between what the patient expects and what the evidence recommends. They may also overtreat or provide ineffective treatments because the treatment feels biological plausible. It is responsibility of those developing clinical guidelines to include an implementation plan to facilitate uptake. The implementation process will include an implementation plan, analysis of the context, identifying barriers and facilitators, and designing the strategies to address them. Education. Training in evidence based medicine is offered across the continuum of medical education. The Berlin questionnaire and the Fresno test are validated instruments for assessing the effectiveness of education in evidence based medicine. These questionnaires have been used in diverse settings. A Campbell systematic review that included 24 trials examined the effectiveness of e learning in improving evidence based healthcare knowledge and practice. It was found that e learning compared to no learning improves evidence based healthcare, improves evidence based healthcare knowledge and skills, but not attitudes and behaviors. No difference in the outcome is present when comparing the e learning with face to face learning. Combining e learning with face to face learning, blended learning, has a positive impact on evidence based knowledge, skills, attitude, and behavior. As a form of e learning, some medical school students engage in editing the information that they have, which increase their EBM skills. They edit the data online and then use it for themselves. And some students construct EBM materials to develop their skills in communication, in communicating medical knowledge. And they, in fact, continue with it. They come along with some very good results. So we can have the anecdotal evidence, we can have the clinical decision support system, CDSS, clinical epidemiology, we can have consensus medical, we can have epidemiology, we can have evidence based dentistry, evidence based designs, evidence based nursing, evidence based policy, evidence based practices, evidence based management, evidence based research, meta sciences. We can have medical algorithm. We can have paradigm shift, the social process by which scientific evidence is eventually adopted. We can have personalized medicines. We can have policy based evidence making. We can have precision of the medicines. And it can certainly help us a lot. The evidence based medicine can be the oral one. That's what we can rely on the account of the history of JAMA, the BMJ, Center of Evidence Based Medicine at the University of Oxford, and we can have the evidence based medicine at Curley, and there can be other references as well as we move along in the study of the discipline that we have chosen for the day.